All right. Well, we're going to go ahead and get started with our panel discussion. We've got plenty of time for all of your questions. And so, any audience questions to start with? I know Dr. Winters had a question just to get things rolling, and we'll be taking some from off the chat as well.
I can talk loud. So, Maite, in terms of the single troponin, I would venture to say as more of that evidence comes out, makes its way into hospital administration, and would love in the current healthcare environment to avoid bringing more patients to the ED with respect to chest pain, OBS, and further downstream testing. In terms of those studies and thinking about the European pre-hospital model, was there a different cohort of providers that went to assess those patients and thereby got the point of care troponin before sending them or allowing them to follow up with primary care?
You mean our ambulance personnel and how they're different? Yes. Our ambulances are staffed by 2 people. Usually there's a driver who has some minor medical training, and then there's the ambulance nurse who is usually an ICU and or ED trained nurse with an additional year of training. I think they're really good in general, and they're able to pick up a lot of stuff. But clearly, the pre-hospital is always so tricky, right? Because they have such limited resources, they have such short amount of time. There's also chaos and things happening. So I think it's very admirable that they want to do this, but they're also highly motivated to keep people home that should not come to the hospital. And I think part of the Aortic trial that is, they're doing the repeat study and like really looking at patient-centered outcomes over just looking at cost reduction. I think it's very important for us to start thinking and incorporating. I'm not sure about the details of incorporating primary care physicians as well, because the system's really good, but it's also under a lot of tension. They're always overstretched. They're very busy. So I think we need to work out a proper way and a safeguard that these people are safely seen by the primary care physicians without us just saying, go see your doctor. We need to make sure that they're included in this as well. So I think that's part of it too.
Great talks, everybody. Thanks for coming. I also had one more question on the troponins. In regards to non-ischemic ACS, how much better are the high sensitivity troponins at picking that up as opposed to like the conventional ones?
It's all the same. It's just really the troponin doesn't care why the troponin was leaked.
Fair.
If that answers your question.
And I think you have to get used to when you make the transition of just seeing that it's not like positive or negative, plus or minus, yes or no. There's a level, and so
Yes.
just not having everyone panic. Like you have a patient come in, who's septic, they're going to potentially have a troponin bump, and they're not going to the cath lab. So.
Susie, I want to invite everybody to chime in for any answers that you'd like to contribute. Also, these are not specifically for one person.
And
So
also,
if there's any battles or debates, even better. Speaking of which, Semhar, go.
I was just going to say it's also the delta, right? Like, so if you have cardiac injury from, let's say, blunt chest trauma and it's positive, it's really that delta that you're looking for, because that delta is going to be very different if you have an acute ischemic event and if you're having trauma and it's an indolent leak from the trauma or from whatever event it is.
I wonder how it is in the pediatric. I'm joking.
Remember that the delta can go the other way too. It could be a decrease. So when you get the actual initial level, you don't know if it's currently downtrending or uptrending. So that's why if it goes down a certain amount, then you still have to have some suspicion for ACS.
But the good thing is you'll have an algorithm.
Yes.
Like your institution will have an algorithm, and often it can be automated, I would assume here, with the lab. So it will be firing the next successive troponin if it needs to be done. So it's not like you're going to sit there and have to try to figure out if the delta is significant. There should be flagging of that.
Some of the electronic medical records even have, like, if you hover over it, the result to see what the normal is sometimes, it will actually give you a little drop down. It's like, result so much, do this, result so much, do that. That's kind of nice. So if you have that opportunity available to you, that would be helpful. Yes.
Yes.
Great talks, everybody. Thank you so much for your time. Dr. Alblaihed, you mentioned the often cardiac arrest protocols are initiated. With that in mind, and obviously bystander CPR should always be a role in the pre-hospital setting for our EMS providers to be using some form of ultrasound, whether that's
Yes. No, absolutely. And a lot of EMS are actually moving towards doing pre-hospital echo, at least. And I think it's really helpful because once they get that view, they can tell if it's tamponade. You can tell if there is activity or not. Sometimes you can tell if there's wall motion abnormality. So depending on what caused this arrest, they can take the patient to the correct center. I don't know, and this is probably a question for anybody with EMS, but if they're allowed to do a pericardiocentesis, right, in the pre-hospital setting. Don't know. But they can definitely do a lot of life-saving measures before then. So I think it's very helpful to have that pre-hospital.
Yes, probably not in the U.S., but I don't know, in Europe, Netherlands, since the pre-hospital personnel oftentimes are physicians.
Not with us.
Not with you all, okay.
The regular ambulances usually are, like I said before, the nurse who's highly specialty trained, and then the other staff member. We do have physicians that go out through the helicopter, or they drive sometimes just because it's faster because it's such a small country. And they do use ultrasound for, say for like, sometimes for cardiac arrest or for trauma. But those are limited calls. So the majority of ambulance rides, people are not able to do ultrasound. And also, I think the data on that is not great.
Back when AEDs first came out, they were only being used by medical personnel, and now you walk through the airport and every 300 feet there's an AED, break glass for AED. Leen, do you think it's just a matter of time before we have ultrasounds in the airport?
It's kind of like the video laryngoscope, right? Right now, it's almost every EMS truck here has them. I don't know about Europe, but like it's something that it just takes time. Then everybody has the portable ultrasounds. It's all in your pocket right now. I think it's really helpful. I know some EMS colleagues of mine do try to use it pre-hospital, and if they see heart activity, they know it's pseudo-PA. You will just hang that epi-drip. You won't just give slugs and do, right? So it changes the management. I think it's helpful.
Dr. Gabriella, why don't you take one question off the chat?
Absolutely. Dr. Farzad, I'm going to put you in the hot seat. So there was a question about whether if a patient has baseline right axis deviation, if there's any utility in looking for like a worsening of the axis, like developing extreme axis. Is that like ever clinically relevant or something that you look for?
Yeah, that brings up a good point. Always you want to, whenever you see any ECG abnormality, you of course want to compare it to a prior ECG and see kind of how it's progressing. And interestingly, that like S-wave in lead 1 is something with a lot of the conditions that I mentioned. As those pathologies worsen, so will the depth of the S-wave in lead 1. So for sodium channel blocker toxicity, hyperkalemia, as those things get worse, sometimes it may not be a full axis because the S-wave is not very pronounced, and you can be more sensitive when you're evaluating for right axis by just saying, hey, this was a totally upright QRS previously, and now I'm seeing a little S-wave, and I have suspicion for a drug toxicity. Let me repeat the ECG in 15, 20, 30 minutes and see if it's progressing more. So it could heighten your suspicion when you just see a little bit of an S-wave and see kind of how that's progressing depending on the etiology that you're worrying about. But it's a great point to always compare to a prior one and see if this is all new and track it and trend it, which is why I mentioned the texts and how much I appreciate them, because I commonly do that. And when something's off, immediately go look at the old one, look at the prior one, compare them closely together, and then track them and trend them, especially when you have a high clinical suspicion for a specific entity.
My question was, just what are your thoughts on, like an aortic dissection, or I guess type A aortic dissection resulting in tamponade? Obviously, like usually it would be like, that would require surgical intervention. But when we were talking about like doing a pericardiocentesis and pulling the fluid, like you would also probably hopefully be able to see it on the echo. But what are your thoughts in general for management of that in the acute setting? Like, would you still be trying to pull some fluid to help with the obstructive shock if it's from the dissection?
I would pray a lot. If you do see the dissection flap in the aortic arch and it's causing that tamponade, I'm going to throw this out to people with more experience, but I would be reluctant to put a needle in there. I would call my surgeon to take him up. But I don't know, it makes a good, it's because usually blood congeals and coagulates, so it's going to be very hard to aspirate that blood. But has anybody been through this and or has experience to answer?
I haven't personally seen this case, but it has come to our institution and it's talked about frequently. And our specific cardiothoracic surgeons are like that there's very little utility in doing much for that because they're not stable enough to get to the operating room. Even if you're doing a massive transfusion or putting in a drain, it's continually gonna drain out, and it's just not compatible with life. So there is sometimes a hard stop there, but I think from our standpoint, when it's not clear, you're not sure if you're seeing a flap or something, it's worthwhile trying to do a pericardiocentesis. But if you put a drain in there or getting endless blood flow that's not stopping, I don't think there's much we can do in today's world of medicine to stop that.
I think
Definitely, sorry, go ahead.
I think that it depends at, number one, your institution, right? What are your capabilities? Do you have someone upstairs that can come down immediately? And number two, is there a pulse or not? If you have a person that has no pulse, you see a small amount of fluid, and obviously you think that this is from a dissection. If they're young, I will pull, right? Like, it's not harmful, the person is dead. So pull in anticipation, and if you get pulses back, you call your surgeon. That means you have an institution here at trauma. We can do that. We have done that before. I have also seen congealed blood in a person who's had a type A dissection, discharge and return, and also in arrest and have pulled blood. It was congealed and difficult to get out. We did get it out, put a chest tube in, 500 cc's went out, they lived, they went to the OR. So I think it is place specific, your resource specific, and also how quickly, like, did the person just go down, just have cardiac arrest? Right, you take off 20 cc's of whatever out of the pericardium, you should get pulses back. The question is, do you get pulses back? Otherwise, it's going to be a clamshell, and then you have a different situation.
Or I think your patient was just afraid to die in front of you.
Not going to happen.
So when Dr. Whitting and I were at Mercy, I don't know if you remember, but we had, I don't think it was either of our patients, but I recall during our time there was 2 aortic dissections at Mercy, both got pericarditis and TCI, and one got transferred to university and survived, the other didn't.
Yeah,
so,
it definitely happens.
You know, and that was a transfer, so it was a dramatic save.
Yes.
But certainly not a standard of care and probably not very common.
Correct. I think there is a criteria, the Halpern criteria, that talks about when urgent pericardiocentesis should be done versus you can wait 24 hours. So these are your people, right? Like, we know that echo findings are sensitive but not necessarily specific. A lot of people are hypotensive, but again, the critical care spectrum is wide. There are hypotensive people that are not, that don't need to be pericardiocentesis immediately. They have been hypotensive for some time with their malignant tamponade, or malignant effusion, I should say. So the physiology of tamponade there is a little bit unclear, and so there is a criteria you can use, and the exclusion criteria says within the Halpern criteria, if you think there's a dissection or a surgical cause, don't do it. And that means, right, they have pulses, and so you're calling a surgeon to say, let's go to the OR, as opposed to doing the pericardiocentesis there, because all you're going to get is some blood out.
We had this case I had this case in residency, and it was not a dissection, but ruptured aorta that was just a small part of it that was bleeding into the pericardium. We did a pericardiocentesis and then took off very small aliquots until they were more stable. We also gave blood and then also reduced their MAP goal. That was also important, so that you could allow their chamber size to fill without having the actual tamponade. After doing that, we were able to get them to the OR. They did make it through the operation too.
Remember, Charmy, that tamponade is a clinical diagnosis, right? I didn't go into pulsus paradoxus and how to do it with echo through the valve, but there are other ways. But if the patient clinically looks okay, you're good to wait. And if it's rapid accumulation, like in dissection, small amounts will make a difference if you pull it out. So.
Boy, thank you for all the great talks. Those are incredible. I appreciate all the work you put into them. The question I had pertained to Maite's topic, but I welcome anybody to chime in on this. We all got pretty comfortable with the heart score and being able to discharge people with scores of 0 to 3. And now we have highly sensitive troponins, which give us a lot more evidence against ACS than we ever had. That's led me to sometimes discharge people with heart scores of 4 or 5, and I often do shared decision-making with them. To what degree have you used the heart score and discharged people with higher scores, 4, 6, 7 even? Are there other risk assessment tools that might be better, now that we have the highly sensitive troponins? So.
I do not know of one that's necessarily better. Like I said before, you can pick whichever one. I do think I have discharged people with higher heart scores, and it really depends on what your score is made up of. If your troponin is 50, your high sensitivity, then it's a different story than we have an elderly patient with a lot of risk factors, right? For those people who come in with a borderline concerning story and you have a delta troponin that's negative, but they're 75, their heart score is going to be much higher. And I think for those people, it would be fair to say, hey, can we safely discharge you home? Versus if they have other factors like EKG changes, which is also incorporated in the heart score, or the troponin is elevated, that will make me a little bit more concerned about sending those people home. But there's not a set, if your heart score is made up of so-and-so, the risk is better or worse. But I think it's an interesting question to ask.
I would suppose my other thought would be, why don't you use another risk score instead of the heart score, or like the EDAX score, that of course age might be a reason to rule out, but otherwise is not as restrictive if you have multiple risk factors and looks at other criteria. Because then they could score moderate on heart, but maybe dischargeable on EDAX.
I think the important thing here is using all these scores and these pathways to support your clinical thought and decision on what you really think is going on with them. I mean, we've been using the heart score for a really long time. I have experience with this at my institution. We went to a high sensitivity troponin, and we currently use high sensitivity troponin plus heart score to risk stratify people. And we commonly discharge people that have moderate risk heart scores with shared decision making as well. But it's really important that the heart score is used correctly, right? I see people that have chest pain that probably shouldn't have even had a troponin get heart scored, and then the score is maybe in the moderate range, but it's only because that person is elderly and they've had, cardiovascular disease in the past. But there's nothing in the story that is actually concerning about an acute coronary syndrome, and you can get yourself stuck in those situations where the troponin is also mildly elevated for another reason. So there has to be some clinical suspicion for ACS before you go through this pathway. If you remember, the heart score, even if you're scoring a 0, that by definition has to have slight suspicion. And I find that people get led astray when they really aren't clinically concerned. Somebody else at triage maybe ordered the troponin, and then it is counterintuitive, but it creates this cycle of more testing and keeping people when none of the physicians actually think there's an acute coronary syndrome. On the opposite side, there's people that will have a low-risk heart score that I would never send home because they're low risk because they don't have any history and they're young, but I'm giving them a 2 for the history, or I'm giving them a 2 for the EKG, and I refuse to send that person home because I'm essentially, by my documentation, saying that this history is highly suggestive of an acute coronary syndrome, so you don't want to send that person home regardless of the score. So I think the big point there is that you want to use all these scoring systems and tools and clinical decision support tools to support your clinical decision making on what you think is going on. So if it supports what I think is going on, sure, I'll use it. But if it doesn't, I tend to be really reluctant. But yes, we do send home moderate risk patients home with shared decision making. But that's because the clinical suspicion for true acute coronary syndrome is low.
Susie, you've done studies on this. You want to?
Well, I would just add to Ali's statement too, is that you will see that same patient, minimal risk factors, really concerning story. You're not sending that patient home, and their initial troponin will come back even with a high sensitivity undetectable. And we've had those patients, and you end up keeping them, they get a cath, and they have, an LAD occlusion. So I think even with the heart pathway, if you actually take a look at the heart pathway, there's low risk and they can go home. So I think that was really groundbreaking for us at the time because we couldn't send any patients home. And then you have high risk, who we all know are going to stay anyway. But even the heart pathway doesn't really address moderate risk. It's like there's a gap in it. And if you have an OB center, that's great. If you practice an academic center, that's great. I practice in the community where I cannot admit a moderate risk heart score unless I really fight for it, just based on the score. So I think I use it when it's like convenient, like if I really need to sell the story, I'll be like, oh, and they have like a heart score of 7. But I think we know based on the literature that troponin only rule outs, if that's what you want to do, is just trend the troponin that's safe to do. So I have gone basically to, elements of the heart score, like, the history really, and then obviously if there's something on the EKG, and then getting that high sensitivity troponin, like sending that algorithm. But I'm definitely not relying on the heart score because I felt like I almost had to like calculate it, be like, oh, okay, I'll document it because that makes sense and like supports it. Or if they're moderate, I'm like, oh, I'm just not going to mention it in my MDM because so it's moderate.
This is how I go about it. Yeah.
Let's take one more question from Dr. Wilkerson about the heart score, then we'll go to the chat.
Great talk, everybody. The most recent guidelines are suggesting using sex-specific cut points for high-sensitivity troponin. Are any of you incorporating that? And is there data to really support using that?
We do at my shop. There's a specific level where it'll turn red on your lab results and it'll tell you if it's positive or not. And that's different for women and men. And I think the guidelines would support doing that. And then the deltas in that low range are pretty similar. It's a big growing, when you first go to high sensitivity troponins, it's tough. Everybody has a lot of trouble dealing with them. And they're commonly markedly elevated in a lot of different conditions. Like we all have end-stage renal patients where we've kind of become numb to it because their troponins are always at 400 or 500. So the trend is really, really helpful with dealing with positives. We tend to talk about the low risk and when it's negative and when you could send it home. But these things are really, really sensitive, really inspecific. So the trouble becomes those gray zones where they're actually positive and you're trying to figure out what to do with the positive ones and not have to admit those unnecessarily. So I think the universal definition of MI still applies, which was published long ago, but a trend where there's a greater than 20% rise or fall is more suggestive of myocardial infarction as opposed to just myocardial injury of whatever secondary cause. So we use that to help determine how much of this delta is significant and what do we need to do about it.
And we also use the sex specific, and that's something that your manufacturer, the assay manufacturer, would be able to recommend to you. I mean, you're not having to invent an algorithm. I would say that for the rollout because it seemed overwhelming before you've like moved on. Whoever's in charge of that here, just provide as much education as possible. I started talking about it, I think 6 months before, and like bored people like to death. So by the time we launched it, I think everyone was like pretty ready for it. We had a big birthday cake welcoming the high sensitivity.
We've been talking about it for almost 2 years now, actually. So,
so
all right,
ready.
let's take a couple of questions off the chat. Dr. Miller?
Okay. All right, this is a question that the person proposed to the entire panel, but I think really in relation to Dr. Twelde's talk regarding cardioversion for patients with new onset AFib. And they were wondering if you guys have any hard cutoffs that you've developed in your practice about when a patient had been in AFib for too long to cardiovert safely.
I suppose it is dependent on stability. So if the patient is obviously stable, there's a lot of touch points as far as what is the appropriate time. It shouldn't be a one or nothing thing, meaning we talk about this 48 hours, right? They're coming in after 48 hours. Studies really show that that is a rough mark, and actually less than 12 hours is the better mark that you're really safe from the thromboembolic risk. That being said, at 12 hours, between 12 and 48 hours, you're supposed to also look at your CHA2DS2-VASc to see what other things may make them higher risk. So between 12 and 48, there is a small chance of increased thromboembolic risk, and it depends on where you lie on the CHA2DS2-VASc. So a low CHA2DS2-VASc or 0, and it's less than 48, I cardiovert. That should be the way to go, right? The newest guidelines, 2023 HAACA, say less than 48 hours, new onset, CHA2DS2-VASc 0, get them out of the rhythm. Rhythm control is the way to go. It's going to prevent all the long-term sequelae. So I'm not sure if that answers the question. I'm happy if there's any other part of that.
I think what complicates this a little bit is that not a lot of people know the exact onset.
Correct.
Most of the patients I've seen is like, oh, I don't know. So we don't know exactly. So at that
100%.
point, I go to rate control rather than rhythm control.
Certainly. And I think the guidelines also say that in the, us as EM providers are worried. We don't want to cause, strokes.
Yeah.
That being said, make sure that you are setting up that 30-day follow-up so that they can get their echo and then get rhythm control. The answer shouldn't be give them a rate controlling agent or metoprolol based on risk factors and what's more appropriate, right? If I have a CAD or a diabetic patient, they're getting metoprolol. If I have a hypertensive patient, I'm giving them DILT. They have a robust vasculature. So if I give them either of those, I give them that prescription with a cardiology follow-up so they can get cardioversion because I do not want them to develop longstanding or permanent AF.
And the big question, the big concern with AFib really is not the patient in your department if they're stable. The question is, that's the number one risk factor for strokes. So, sending them home on a DOAC or making sure they have follow-up in a day or two to get started on the DOAC, that's really the question because they're probably going to end up spontaneously converting when they leave your department anyway. So what you do in the department if they're stable is probably less important once you've addressed their future stroke risk. And that's what I tell the patients too. I tell them not to look at the monitor if they're asymptomatic and to worry about their future risk of stroke.
Excellent, thank you guys. We're gonna ask some more electricity-related questions. So the discussant is curious to know if you guys have any thoughts on synchronized cardioversion and pulseless VTAC as opposed to desynced defibrillation. They're commenting on that it should be electrically and mechanically similar to a treatment of VTAC with a pulse and respond better to synchronized shocks, but they're saying that there's a paucity of data, and they were wondering if you guys have any personal experience with that.
I'd imagine that it's difficult to capture, right, to know in that state. So unlike a normal PQRS, where your machine can map that out, right, like when you are both hypotensive, so not exerting as much probably force that you can see, and then more irregular, it is not easy. So I would not sync it.
All right, Dr. Menon, an electricity question for you. Are you doing overdrive pacing for polymorphic VTAC, or is this for poly and monomorphic VTAC?
You can do it for both.
Okay. Any thoughts on labetalol for STORM as well? There was another common question.
I don't think there's too much data on labetalol. It is non-selective, so there's, I guess, a theoretical risk or theoretical benefit compared to more selective options, but I don't think there's good data on it.
And Dr. Alblaihed, for you, there was a question about if you see a patient in arrest and they have a very dilated RV, you're not sure whether this is acute or chronic. Are you doing DVT ultrasounds in your patient's cardiac arrest?
I don't have time to do DVT ultrasound in patients with cardiac arrest.
Listen, you were so good at ultrasound. We think that you may be able to do this. Yes.
No, I'm not. No.
Okay.
I do treat clinically though, but if it's a last ditch effort, I will throw thrombolytics on that patient before I call the code and just give it time to circulate.
Okay, great.
Gabby, with regard to your last question about pacing, also don't forget you do have drugs in your armamentarium there. Isoprel is a great drug to overdrive pace that is often available in the Pyxis. So, right, it's a beta agonist that works sometimes better even when epi is not working and you need to overdrive pace, specifically in TDP, torsades.
Have y'all ever mechanically overdrive paced?
Yes.
I've only done it chemically. It was a good experience. We were able to
That's
get
fun.
good capture, and yeah, I've been waiting to do that. But either isoproterenol or epinephrine has worked pretty good for cases where I've done that.
I have a question for any of you, and I think this originated from Rohit's lecture, but it's really relevant to everyone. So in terms of treatment of cardiac arrest, with regards to electrical storm, because elevated sympathetic tone is such a big part of that, and also persistent V-fib, elevated sympathetic tone is such a component of that. At what point do you say giving more and more and more epi is detrimental to, what point would you say, I'm done with epi, and we might actually consider going in the other direction and giving beta blockers?
I think once you hit that criteria, 3+ shocks, or if they have an AICD, 3+ ATP events, then you should put your this could be electrical storm hat on, and then that's when I would probably deviate from the traditional ACLS.
So after 3 shocks,
Yeah.
giving no more epi.
If there's the risk factors that we talked about, and particularly high risk for storm, then after the 3rd shock, if there's interruption, if there's conversion to normal sinus rhythm, that's when I would start thinking about electrical storm and change my management.
Rest of you, any other thoughts? Farzad.
I'm starting to use epi
Dr.
less and
Alblaihed.
less because in general, not just electrical storm, but in any cardiac arrest, because data has been showing that high dose epi is more damaging than it does more harm than good, and also patients who do survive don't have good neurological outcomes. So I don't exceed 3 doses, if any. So.
Yeah, I would agree with that. Typically, the patients I see have gotten 3 to 5 doses of epi before they even hit the door.
Right.
If that hasn't worked, the chances of me giving more epi is unlikely to help. So I guide my management based off bedside ultrasound and what you think is going on. If you do see that like pseudo PEA type of picture, I think hanging an epinephrine drip where you're titrating to some kind of endpoint is much more effective than just continuously slamming something that hasn't worked multiple times already and could be harmful.
Thoughts from the other side of the table?
I wanted to make sure I understood the question correctly. So you know a person is in VT storm, then that has caused cardiac arrest?
Well, the question was with cardiac arrest. They didn't specify VT storm, but part of the definition of VT storm is intractable VFib.
Yeah.
And this person has been persistently in VFib. At what point do you say, I'm done with epi, I'm going to...
I would, sorry, go ahead.
I just wanted to say the practical point of that is technically really hard to do because you have to really convince your staff. So take that into consideration. If you're already thinking about that, maybe it's a good time to do some teaching with your nursing, to talk about this kind of stuff, maybe before you actually get that patient. Because I've tried certain times to stop giving the epi, and it's hard to do.
So benzos for the staff and then beta blockers.
Yes, benzos for everybody. A little bit of vitamin H, vitamin Haldol throughout the department. It's always great.
Well, that could prolong the QT though.
Yes, that would not for the patient.
Any differences out in
Well, I
that
actually
thing?
had more of a follow-up question for Rohit. So I'm in my emergency department, and we actually have weeks where we don't have EP available. Like last week, we had they sent an email like the night before, and they're like, oh, FYI, we have no EP Monday through Friday because it was someone's vacation week or something like that. And so I'm seeing a patient in storm. Do you think it's like realistic for me to try like Google stellate ganglion block? Like how widespread is this done in the US? And if so, I've tried the other things. If so, do you have any, I looked, there is no MRAP fast card or whatever those are called yet for that. Is there an online resource you'd recommend that I use?
There's a couple. There's the Internet Book of Critical Care has some, and then there's videos that Dr. Savastano have put on YouTube. He's speaking to an audience of cardiologists, but he still shows the anatomic and ultrasound methods of how to do it. And then there's also a couple of other indications for stellate ganglion block, like chronic pain syndrome. So there's a couple of other specialties that utilize it as well, like plastics.
Yeah, it's usually anesthesia.
Well, yeah, my husband does it. He's anesthesia, but I mean, we're not credentialed, right, to do these, so you're going off what you're credentialed for. Would you, in my position, be thinking of doing that?
I think if you are absolutely stuck and you're not in a position where you can safely transport a patient for mechanical support or other expertise, if you have nothing else to offer them and they keep arresting, not just going into ventricular arrhythmias that are stable, but truly arresting, then that's probably the point that I would pull the trigger. At our institution, I don't know if we'd get the opportunity to do that because we have ECMO, so that's why in the mnemonic that I made, I put it all the way at the end, even after mechanical support. But as you saw from the STAR study that was performed, there's a lot of people who weren't on ECMO or even intubated. So there's people who are doing it internationally. I don't think it's ready for prime time yet, but maybe if there's enough studies that show the benefits, then it could be something that we could eventually in the future be trained to do.
It seems like another situation when you really want to be aligned with your nursing staff. Otherwise, you've been coding for someone for so long, and then Susie just came there and stabbed him right in the top, in the front of the neck, and either it worked and you're a hero, or she killed him.
Or safe.
At least then you can transfer the trauma patients out.
There you go, penetrating
All right.
trauma of the neck.
Kind of going back to the original question a little bit, if you have that cardiac arrest patient, you get pulses back, and then you lose them again, do you start all over? Or are you still taking into account the previous doses of epi in terms of your decision about whether to stop giving more and more and more and more doses of epi? Thoughts from any of you?
I think the best person to ask is Dr. Amal Mattu. I actually don't know the answer to that. I would love to know. Like if they gain ROSC and then they code afterwards, I don't know.
Well, I don't think there's an answer, but you all being experts in emergency cardiology, I think we're interested in knowing what your practice is, because there probably is no standard of care. And so it's always interesting to find out what other people who are cardiology nerds might want to do.
I think if there's a reversible cause, then you address that first and foremost. Is there actually a reason why after ROS they rearrested? And you try and go after that. And in that case, for the first 1 or 2 times, I would repeat, just follow ACLS. And again, after the 3rd time, that's sort of when I have the suspicion of, am I missing something? Or is this actually electrical storm, in which case all the epi that I'm giving them is precipitating it further? That's my threshold.
I guess most of the time they would be, once I get ROSC, usually they are placed on an epi drip or a nor-epi drip because of the hypotension. I don't know if there's any utility in doing more epi if they code again. I'm just speaking out of.
Well, you really have to think about why is their blood pressure low, right? Because they're in VFib. And we know epinephrine's not going to help the VFib. So you really have to think about about that versus just thinking of, they're in arrest, so I need to give them epi. If you think and going back, like you were saying, what is the underlying cause of this, then it makes less sense to throw more epi at it because it's not going to improve the blood pressure if the heart is not squeezing.
True. You know how you can diagnose VFib?
That's good. No, appreciate hearing it's not cookbook, but you have to put some serious thought into it. So, Dr. Miller, any other questions coming up off the chat? While you're looking through that, one of the other questions I got, I think, was largely for Susie. Let's see if I can. You mentioned that SVT doesn't generally cause syncope. Does that apply but then you talked about WPW. Would that statement also apply to SVTs with WPW or primarily just the run-of-the-mill SVTs?
That's a good question. No, it would not apply to that, so that would be a caveat. So, and I also didn't mention, AFib can cause syncope, and Semhar got into it if you have, a patient with a horrible EF or a left ventricular outflow tract obstruction, those are the cases. But by and large, just simple SVT will not. The problem with the WPW and SVT is that your rates can go really high, like 200-300s, and no one can tolerate that. So that's the mechanism of syncope in a patient who has underlying WPW.
And if you have a WPW patient who comes in after syncope, you get the EKG, you got WPW, do you prophylax them with procainamide so that they don't go back into it during admission or as an outpatient?
I think the majority of patients with WPW, it's going to be an incidental discovery. So that the more common scenario is that you get the EKG for who knows why. It could be not related to syncope and you see the WPW, and then what do you do with that? The management is really complex, so not all of these patients are getting, EP interventions or ablations necessarily. So I would actually call my cardiologist in this case and give them the clinical scenario and see if there's any utility to bring the patient in, if they need to be on any sort of medication. I don't think I'd prophylactically throw anything at them in the ED though.
I was very disappointed when I found my first WPW, because in my mind, you know, this whole group of cardiologists would come down waving flags, bringing gifts, and they were like, okay, thanks, we'll see the clinic in 2 weeks. I was like, no, but wait. They are a little bit more relaxed when it comes to these people.
I think, for WPW, it's important to realize or kind of figure out what's making your rhythm. If it's the SI node, if the SI node is in control and the patient happens to have WPW, you're fine. But if there's any type of arrhythmia, if the patient has a lot of PVCs, if the patient has AFib or SVT, that's when I would worry and be like, okay, I can't send you home because you have that accessory pathway. So it just makes a difference who's controlling the rhythm at that time.
Yeah. I think the question was more related to the person came in because of syncope. And now, like most of syncope patients, they're sitting there saying, Doc, I feel fine now. They're back in sinus rhythm. And so you're extrapolating back and thinking, well, maybe they syncopized because they had a WPW arrhythmia. And that was the question pertaining to whether you prophylax them and also, I guess, how urgently you're getting.
Here they get seen within 5 days, generally, and you don't prophylax.
5 days,
keep them on a monitor, though, right?
Meaning, no.
You won't keep them on a monitor for 2 or 3 hours in the hospital?
Oh, meaning they're coming in for syncope? Yeah, sure. But I mean, like, if they are now back, so they have a known history of WPW is what we're saying. They come in after having a syncopal episode. They're watched in the ED. Generally, those people are already being followed by cardiology. It's not unless you're now getting an ECG post-syncope and you're seeing WPW, in which case, here at the academic center, our cardiologist will, usually I've seen them, it depends, but I have seen them discharge some and then some come in.
I guess we have one other audience question from Yusuf.
Question mainly to Dr. Farzad, but also to everyone on the panel. Thank you everyone for the talks today. We are taught never to trust the machine when, reading an EKG. Now with AI, do you see a future where machines will be able to, give us with almost 99% accuracy the diagnosis?
Certainly, the things will get better. The interpretations and the computer's ability to interpret stuff will get better. We already see that with apps for ECGs, but it seems to be a big trend in everything from business to companies. Everybody's looking for ways to incorporate AI, so it'll certainly get better. I don't think we're anywhere close where you can completely trust it. I think it's gotten really good for OMI currently, but it's not all encompassing or at a point where we're no longer needed. I think it has the potential with machine learning and AI to get there, to definitely support it, but you still have to kind of correlate all these findings clinically with the patient that's in front of you, and I think that's where the most of the value is. But I anticipate it all continuing to improve.
We're not obsolete yet.
Not yet.
That you're going to ask whether machines will be able to do your shifts. So, all right, we're taking a sick call. All right.
All right, a couple final questions. One just came through the chat for Dr. Alblaihed. The person was wondering if you could sort of define cardiac activity. There's some like incidental quivering seen, and sometimes it's anxious making or anxiety provoking to call that true cardiac activity, or is it actually pseudo-PEA? Do you need to see valves opening? Do you need to see organized activity? How do you define that?
Yeah, so if there is any cardiac activity, you should see the mitral valve opening and closing. You can see some of the myocardium contracting, even if it's a tiny bit. If you don't see the valves opening at all, and they're just closing, and they're just like still, there's swirling of the blood in the right ventricle, there's no cardiac activity there. So I think that's.
And then regarding treatment for atrial fibrillation, there's a question about whether you guys have ever appreciated some kind of synergistic effect between diltiazem and magnesium causing bradycardia. I haven't experienced this, but the person was saying that they had seen that multiple times in patients.
Can you repeat that? Patients on magnesium and diltiazem together producing bradycardia?
Yeah. I don't think I've seen it either, but just putting it out there.
Sure. Diltiazem will cause.
Because that would be my question. Because we want them.
Maybe they're suggesting that they act synergistically to produce excess bradycardia?
Yes, that was what the question was. Yeah.
I've never seen that. I mean, in a sick AF patient, generally I wouldn't give diltiazem because of the, right, like negative inotropic and significant hypotensive effects. So I would wonder if it's just the diltiazem as opposed to both of them causing that kind of AV nodal blockade, personally. So. And I don't know that I think that's, I mean, that's not synergistic in the sense that synergy generally means there's a good thing and that's a bad thing. So, although in AFib we do want the heart rate to be lower, right? Like they generally don't go from AFib to bradycardia unless there's a sick sinus syndrome, and that's something completely different, in which case you shouldn't have given an AV nodal blocker, right? More people are going to syncopize from a bradycardic event, meaning like a heart block or sick sinus node or something like that, than AFib. We already discussed like AFib is a rare cause of syncope, much more infrequent. Now, when a person comes in and you have a heart rate of 50 and they tell you I passed out, and then they go into AFib, and you're worried, the heart rate they came in was 50 and now they're in AFib. Your thought should be they syncopized because their heart rate was 30. So be careful giving them an AV nodal blocker. Just put pads on that patient and prepare in case you need to pace them. And that patient should be admitted. I hope that makes sense.
Got one final magnesium question. I don't think I've seen 2 grams of mag produce a whole bunch of hypotension, but the person was wondering if there's a specific cutoff for blood pressure that you guys use, sort of saying, magnesium is not appropriate for this patient in the context of AFib.
And generally, I'm giving it as an infusion over an hour, so it's not going to cause that. It's right when you push it in, like a preeclamptic, that you cause that hypotension. That does resolve when you stop, and it's not a reason necessarily to stop it. Because right in your pregnant patient, you're not going to stop it. You're going to allow for that hypotension and push that mag. So it is a transient effect. I wouldn't worry about it. If the patient has renal failure, make sure you're checking the levels after your first infusion bolus after 1 hour.
Okay, great.
I want to be careful about the dosing, though. I'm kind of smirking because when my wife was pregnant with our first, she had preterm labor, and they bolused her with the typical 4 to 6 grams of magnesium, which is not the Hindu dosing, by the way. She's about
Sage-O is very small.
She's about 100 pounds, and so she became hypotensive to 50, diaphoretic, started vomiting. And so I was standing there saying, give her calcium, give her calcium, give her calcium. So it fortunately was transient, but it was a very unpleasant thing to see. I'm sure it was more unpleasant for her. So just be careful about how quickly you push that magnesium in, and also be aware that the textbook dosing is often written for people that are quote unquote average size, and your patient may not be average size.
And a lot of critical illness with magnesium, you're giving it over an hour. Like you're putting an infusion on board.
Last couple minutes, any questions? Any final comments? All right. Oh, we have one. We'll take one final question. Great.
Related to Rohit's lecture, in just treatment of when you see VTAC, you mentioned the slight superiority of procainamide. I was wondering, for us not familiar with giving it, if you could speak to the contraindications and why it's not more widely adopted.
Yeah, the load is 17 mg per kg, and typically the recommended duration is over 30 minutes, but I think to be safer, you push it 30 minutes to an hour. That will prevent or at least reduce the chances of hypotension that's associated with it. The other thing is that, like I said, there's a potassium blocking part of it, so if they already have a prolonged QTC, then I would avoid using that medication.
And you have to be sure they are an actual VTAC, because if they're in one of the mimics, like the hyperkalemia mimic,
right,
that's not good. So be sure they're VTAC.
Yeah.
All right, well, with that, we'll close things out. Please join me in thanking our panelists and speakers here. I think this was a fantastic conference. And we will have our 10th annual conference next year. We don't have dates set, but we'll be sure to email all the folks out there in the live stream land. And thank you all for participating and for asking those great questions. And again, see you next year.
Thank you, Amal.
Thank you.